alcohol to recovery and support group, such as Alcoholics Anonymous. Meperidine hydrochloride, that's Demerol, is the drug of choice for pain due to pancreatitis. Demerol is usually given in combination with anticholinergic agents. These agents reduce vagal stimulation and gastrointestinal motility. Histamine receptor antagonists help reduce gastric acid. Antacids are administered to neutralize digestive secretions. Insulin might also be administered if the client has developed glucose intolerance. Clients who have chronic pancreatitis may also benefit from pancreatic enzyme replacement therapy. Pancreatic enzymes such as pancreatin, that is Viocase, help in the digestion and absorption of proteins and fats. Surgery is usually not the treatment of choice for clients who have acute pancreatitis. Clients who have chronic pancreatitis, however, might undergo a pancreatectomy, the partial or total removal of the pancreas. A hernia is the protrusion or projection of an organ or tissue through a weak area in the wall, muscle, or cavity that normally contains it. The most common types of abdominal hernias are inguinal hernia, found in at least 2% of male adults, direct and indirect, umbilical hernia, which is usually congenital, femoral hernia, which is most common in obese women, incisional hernia, which develops at the site of a surgical incision. With a hiatal hernia, the stomach protrudes through the diaphragm into the chest. Abdominal hernias are also classified as reducible, irreducible, or strangulated. With a reducible hernia, the contents of the hernial sac can be pushed back into the abdomen. With an irreducible or incarcerated hernia, the contents of hernial sac cannot be pushed back into the abdomen, so surgery is required. With a strangulated hernia, the blood supply is cut off to the herniated section of the bowel, resulting in necrosis and gangrene, so surgery is required. Abdominal hernias usually result from a congenital weakness in the abdominal wall. They can develop following surgery, after damage caused by lifting heavy objects, substantial weight gain, persistent coughing, or straining to defecate.
The first sign of a hernia is usually a bulge in the abdominal wall, which might be accompanied by abdominal discomfort. Some people are able to push the protruding mass back through the abdominal wall. The client with a strangulated hernia develops severe abdominal pain and signs of bowel obstruction, which include vomiting, cramping, and distension. So how is a hernia diagnosed? Hernias are diagnosed on the basis of the physical examination and the client's history. It is important to listen for bowel sounds and palpate the abdomen for the location of the hernia. Don't forget that if bowel sounds are absent, the client might have a strangulated hernia that requires immediate surgical intervention. Clients who have reducible hernias can be taught how to safely push the hernia back into the abdominal cavity, but they should not try to reduce an incarcerated hernia. To contain the hernia, some clients wear a truss, which is a pad that is placed over the hernia and held in place by a belt. The client should check the skin underneath the truss every day for skin irritation or breakdown. Surgical repair of the hernia, called
herniorrhaphy,
is a treatment of choice if the hernia is painful, cannot be pushed back, or is likely to cause complications. Complications of hernia include strangulation, bowel perforation, and incarceration. During hernia repair, the herniated sac of the intestine is pushed back into the abdomen or is removed if there is the possibility of strangulation. The abdominal wall is repaired with stitching or mesh. Some clients who are obese or prone to recurrence may require hernioplasty. During hernioplasty, the weakened area is reinforced with wire, fascia, and mesh. Following surgery, the client should be instructed to deep breathe and turn frequently, but to avoid coughing, as it can disrupt the suture line. Observe the client carefully for postoperative complications such as postoperative wound infection, dehiscence, and evisceration. To prevent recurrence of the hernia, instruct the client to avoid lifting objects weighing more than 5 pounds for at least 2 weeks following surgery. Also, encourage the client to prevent constipation and straining at stool by drinking plenty of fluids and eating sufficient fiber. If the client is obese, arrange for a dietitian to set up a weight loss program.
We'll will now turn our attention to the second most common cause of cancer deaths in the United States. Colorectal cancer, the fourth most common type of cancer, is a malignant tumor that involves the colon or the rectum. The most frequent site is the rectosigmoid colon. What are the risk factors for colorectal cancer? Family history of colorectal cancer. History of ulcerative colitis. Male gender. Age over 40 years. The presence of numerous polyps in the large intestine, called polyposis syndrome. Adenomatous premalignant polyps. High fat. Low residue diet, and ingestion of large amounts of red meat. The exact etiology of colorectal cancer is unknown. The tumor originates in the mucosal and submucosal layers of the colon and rectum, and then invades deeper layers. Once the cancer cells spread to the lymphatic system, liver metastasis is common. In the early stages of colorectal cancer, the signs and symptoms of cancer may be vague. However, clear symptoms appear as the disease advances. It is very important to obtain a description of symptoms from the client and to perform a physical assessment. Clients who have colorectal cancer experience fatigue, weight loss, bloody stools, and abdominal distension and tenderness. They often report overusing laxatives and are at risk for anemia due to rectal bleeding. The healthcare provider might discover an abdominal mass late in the disease. Cachexia, a state of extreme malnutrition and wasting, develops as the disease advances to a terminal stage. Colorectal cancer is diagnosed on the basis of these diagnostic findings. Low erythrocyte count due to chronic blood loss. Low hemoglobin and hematocrit due to chronic blood loss. Stool guaiac positive for occult blood. Tumor evident on proctosigmoidoscopy.